this will be the current format of my talk. So first of all, I think since the topic is liver disease in infant, I think we can broadly classify with infants having liver disease with jaundice, which is otherwise called as infantile cholestasis. And one more infant who has hepatomegaly but no jaundice. It could be due to anything like an infiltrative disorder or a storage disorder or a malignancy. So first of all, let me start with cholestasis of infancy. So always when a newborn or an infant is there with jaundice, we always have this first question, whether it is a conjugated or an unconjugated jaundice. Let's just go through the physiology initially. I think when the RBCs break down, the unconjugated bilirubin is lying in the blood and it is taken up, combined with albumin. It is taken inside the liver. It is conjugated inside the liver by two specific enzymes, and then it is excreted out of the liver. So basically, this physiology matches with the onset of clinical conditions of either unconjugated or conjugated bilirubin, jaundice. So conjugated bilirubin is usually excreted via kidneys and excreted via the liver. And when there is an obstructive jaundice, then it gets excreted via kidney because it is a water-soluble fraction. Unconjugated bilirubin is not water-soluble. So the symptoms of cholestasis is basically based on these two scientific phenomena. So as I already mentioned, the first exercise is to basically differentiate between conjugated and unconjugated jaundice. Whenever a child comes to us for a consultation, we should ask the mom whether the child had a high-colored urine, which is staining the diaper, and whether the child had a pale stool or a white stool, which speaks of actually cholestasis. If any of the above history is positive, we need to think of conjugated jaundice, which is always abnormal actually. What is conjugated hyperbilirubinemia? When a serum bilirubin is more than 20% of total serum bilirubin, it is called as conjugated hyperbilirubinemia. ISFEGAN also defines when the total bilirubin less than 5, if the bilirubin is more than 1, the conjugated bilirubin is more than 1. Again, you call it as a conjugated jaundice and cholestasis of infancy. What happens secondary to cholestasis? The main toxin is the bile acid. The bile acid is like a soap. It damages the hepatocyte membrane, causes frank hepatotoxicity, leads to end-stage liver disease, actually portal hypertension. Bile is also necessary for digestion. Since the delivery into the gut is decreased, that lead to malabsorption and rest of the consequences of cholestasis. So primarily it causes the damage to the hepatocyte, secondary effect of malnutrition. This is a broad term for basic classification of cholestasis. It can be classified, initially they used to classify it as extra and intrahepatic. Nowadays, we know that there is a lot of overlap between two. Extrahepatic can be cholangiolar, intrahepatic can be due to an interlobular bile duct related paucity, or it can be due to a direct injury to the hepatocyte, which can be due to various reasons like metabolic disease, viral disease, and neonatal hepatitis. Next topic is the clinical approach. We know that infantile cholestasis is like a textbook of mystery. It is in fact a box of mystery. We can see the entire list there and a lot of queries down because each and every time, whenever we get nothing, then we do a genetics and a new gene is coming up for genetic causes of cholestasis actually. Why we have to evaluate a child coming with cholestatic jaundice? First of all, the ISFEGAN, I think they recommend that we need to identify a sick child with cholestasis, obviously because it is like a triage phenomenon. We need to identify who is going to take it faster. That is the first aim. Second is to identify the disorders which are amenable to surgical therapy on the right time, and also to avoid surgical intervention in certain intrahepatic diseases. So strikingly, we can see that who is sick and who is non-sick. The kid on the left side of the screen is obviously a non-sick child who is smiling actually. The child on the opposite side is quite sick. A child who is not feeding well, who is lethargic, encephalopathic, hypoglycemic, child has active fever, bleeding from sides, and child who has severe failure to thrive is defined as a sick child. With the textbook of the box of mystery, this is how it can be simplified. When an infant comes with cholestasis, you classify it as sick versus non-sick. Sick infant, first thing to do is sepsis screen because 2/3 of the infants with metabolic diseases will have a sepsis that is there, which would have triggered the metabolic crisis. Then even if the sepsis screen is positive or negative, usually we need to screen for a few metabolic diseases if there are other failure to thrive or rest of the stigmata of metabolic diseases, which include the gall tussity, urine for sectional run, etc. If the infant is non-sick, then we look at the stool color. If the stool is echolic, then we need to think of cholangiolar causes or issues with the bile duct. And the number one thing that we need to rule out is a biliary atresia. If so, subsequently, we do an ultrasound and see the most important pathology that is identified by an ultrasound is actually a choledochal malformation, because the sensitivity to diagnose biliary atresia varies in ultrasound. But when there is a choledochal malformation, it is diagnosed with an ultrasound and the child goes for surgery. If the child has apparently a normal stool actually, then we need to see for the gamma GT. Gamma GT is normal in genetic cause of cholestasis like PFICs and bile acid synthesis defects. So etiology of sick infant is quite broad. Infections, especially HSV infections, sepsis, UTI can cause. Metabolic disease, I've given the list. For practical purpose, it is galactosemia, tyrosinemia, mitochondrial disorder that we see commonly. Immune-mediated disorder is hemochromatosis, which is otherwise known as gestational albumin disorder, which is actually more commonly seen in the West, but in India also we are seeing it quite frequently nowadays, and the rest of the causes are extremely rare. There are certain clues from history we need to see. If there is a persistent clay-colored stools, we have to rule out biliary atresia. Metabolic liver disease stigmata I already mentioned. If the child has an abnormal body order, for example, tyrosinemia, they have this cabbage order, rotten cabbage order. Sweaty, the salty taste of the sweat. I think we get this history. I think if we ask them actively, they give this history that the salt is, the sweat is tasting a bit salty in cystic fibrosis. Cardiac illnesses are seen in usually biliary atresia and the Alagille syndrome. IUGR babies are seen in hemochromatosis and mitochondrial disorder. If the mother has itching during the antenatal time period, there is a high chance that the child is suffering from PFIC 1 and 2 or even type 3 PFIC. Torch infections, even though we say about it quite commonly, I think it is extremely uncommon to see a torch infection nowadays leading to a cholestasis. And on clinical examination, if there is a severe failure to thrive, metabolic remains the number one possibility. Dysmorphism speaks of Alagille syndrome. It can be due to many trisomies, which leads to cholestasis. Florid rickets is a part of renal involvement, usually in tyrosinemia and hereditary fructose intolerance. CNS involvement or multisystemic involvement is usually small molecule disease, which are mitochondrial disorders, urea cycle disorder, or organic acidemias. Cataract is characteristically seen in galactosemia, that is an oil-drop cataract, and sometimes in Zellweger syndrome. We look at some clues from the LFT. I think I've already mentioned about the gamma GT. Alpha fetoprotein is one investigation which can sometimes clinch you the diagnosis. It is usually in lax in tyrosinemia. Sometimes it will be very high in type 5 PFIC. And very high values can also be seen in neonatal hemochromatosis. We have to always look at the bilirubin. Biliary atresia usually doesn't have a bilirubin, which usually cross more than 9 to 10 unless they are decompensated. Deep jaundice speaks of acute liver failure, acute on chronic liver failure, coexisting kidney injury, coexisting sepsis, or a cause of hemolysis like G6PD, or again sepsis, which can cause actually a hemolysis thing. What is coagulopathy? Hepatic-based coagulopathy is based on something that is actually not corrected with an injection vitamin K. If you ask me how early it can be given to see, it is actually 2 hours, but the recommendation is actually to 6 hours and to see if it is getting corrected, because factor 7, if it is due to vitamin K secondary to cholestasis, the INR will become normal. But if it is not due to vitamin K deficiency, the INR will not become normal, then we label it as a liver failure. Brushing through the radiology, ultrasound is diagnostic of choledochal malformation. It can give clues towards biliary atresia. It is not diagnostic of biliary atresia. Liver biopsy again can give clue towards various diseases that affects the liver in this age group. But the gold standard for biliary atresia that we'll be discussing subsequently is always peroperative cholangiogram actually. So the clinical dictum is in obstructive causes like biliary atresia, the growth and synthetic functions remains normal in the initial half of infancy until the synthetic functions start deteriorating. That usually happens in 6 months. That is why the next scenario, this is a 6-month infant who was noted to have this, the same happy child that I had shown before, who had jaundice since 2 weeks of age, which is mild actually. Stool color was also totally pale in color. You can see the stool color, which is totally creamy white. Child was active till 4 months, so the parents did not consult because they felt the child was well. Now they have noted that the abdomen is coming out, the tummy is protruding, and hepatosplenomegaly is there. When the stools are very much clay and pale, then we think of these two possibilities that I've already mentioned, biliary atresia and colorectal malformation. The rest are actually in graded small letters because the frequency is extremely less. What are the differentials of a persistent clay-colored stools? I would always, it is not an error that a biliary atresia, type biliary atresia 3 times there. We have to always think of biliary atresia when the child has a persistent clay-colored stools, because it is a correctable condition when it is rather not correctable. It is a condition where a surgery can temporarily bring down symptoms in biliary atresia. The other possibilities that we clinically see are Alagille syndrome, which they can have persistent pale stools, cystic fibrosis, inspissated bile duct syndrome usually happens in hemolysis and sepsis, and any cause of severe intrahepatic cholestasis due to canalicular edema can also lead to pale stools. Certain ultrasound features are there in biliary atresia, but the sensitivity varies from 80 to 90% actually. And biliary atresia is not EHBA, it is actually biliary atresia because we know that the most common type affects both intra and extrahepatic bile. It is a progressive necroinflammatory disease. These two terms are very important because of these terms, we know that why even if somebody clears jaundice after Kasai, the disease can again recur in the liver. The frequency varies globally. Approximately in Asia, I think South Asia, the incidence is somewhere 1 in 10,000 to 1 in 20,000. They can have associated malformations, including cardiac and splenic malformation, and it is the commonest indication for liver transplantation in children. The commonest type I've already mentioned is the type 3 biliary atresia. Why late referral happens? 2/3 patients usually land up at 100 to 120 days because the jaundice is mild, like as per the initial child. Jaundice is very mild, so it is easily missed. Sometimes the labs are doing only the total bilirubin at 2 to 3 weeks just to see if it is like a physiological jaundice getting prolonged. So the conjugated fraction is not seen in that. And the pale stools may go unnoticed sometimes because the baby will pass both urine and stool together, and sometimes they may mask that thing. Second is the cast from the epithelium, which is stained with bilirubin. It will look like a target sign. So the outside cover is like yellow and inside is pale. So if you cross-section it, it looks like a target sign. So these are the things. So that is why many countries have implemented this patient education thing. In India also, we have done this. This is basically from the University of actually British Columbia, in which they have advised the moms to check stool color every day in the first month of life. This is the practical approach to biliary atresia, what we see. Child landing up in less than 60 to 90 days of life. If they have persistent pale stools, we usually go and ultrasound evidence plus or minus the LFT clues, child has a hepatomegaly clinically, then we directly go ahead with an intraoperative cholangiogram. This was an initial recommendation by the IAP of India, but in our center, we don't do basically a high-dose scan or a liver biopsy when it looks very clinically suggestive of biliary atresia. When a child presents with more than 90 days or maximum up to 100 days, then we don't offer surgery, Kasai surgery. They need to go for a liver transplant. Also, there is a fraction of biliary atresia, which is known as fetal variant of biliary atresia. Even they can have decompensation at 6 weeks and 8 weeks. So remember that even if a child who is less than 90 days or more than 90 days, who has features of decompensation, should never undergo a Kasai surgery. They should be undergoing a liver transplantation. So HIDA scan is waste of time. It actually consumes around 5 to 7 days because we need to give UDCA and then we have to perform the HIDA scan. Liver biopsy is, it actually gives clues towards the underlying etiology. Sometimes it can be with an expert histopathologist, biliary atresia can be diagnosed. That is why the accuracy up to 95% can be seen. There are certain parameters which we see in actually biliary atresia. Intraoperative like cholangiogram is the gold standard. We know about Kasai surgery actually. So this is the survival curve from the initial cohort of patients from King's College, in which they saw that the survival was very good if the surgery was done within less than 40 to 60 days. And when it was done for more than 100 days, the jaundice clearance rate is hardly less than 5% actually. So Kasai surgery will work if biliary atresia is diagnosed in less than 60 to 90 days, and when it is offered. For more than 100 to 120 days, the clearance rate is extremely less. Liver transplant is offered when the child has a failed Kasai. That means if the bilirubin is more than 2, still more than 2, after 3 months of doing the Kasai surgery. It is an interesting finding to see that 1/5 of all those children who undergo a successful Kasai can survive up to 20 years with the native liver. There are some other scenarios where you need to offer a liver transplant, even if the Kasai can succeed. They can have synthetic failure, they can have varices, actually massive bleeding, massive spleen, actually portal hypertension related. Sometimes, even after Kasai surgery, bilirubin is normal. They get recurrent cholangitis. Maybe each and every month they are getting admitted for IV antibiotics. Suspected tumor formation, even after Kasai surgery, because it doesn't completely abate the process in the liver, tumor can happen, and that becomes an indication for transplant, and sometimes quality of life and itching can be there. So this is the gross natural history, which is modified by Kasai surgery, which can be seen in biliary atresia. So when offered on time, 2/3 of these kids will clear jaundice, but unfortunately, one-third of them, and the majority of them will have recurrence of jaundice within 1 year, maybe up to 10 years. The rest 1/3 will survive up to 10 to 20 years with native liver. 1/3 will actually fail to clear jaundice, even if you offer a Kasai at 60 to 70 days of life. There is one more infant with intermittent pale stools, actually. This is a 6-month female infant who is having this symptoms since last 3 months. Somebody has detected a mass in her abdomen for the last 1 month, actually. And the child has actually hepatomegaly. And when you keep the ultrasound there, then it speaks of the diagnosis, which is actually a choledochal cyst here. So this is basically a cystic variant of choledochal cyst, the type 1A choledochal cyst, and the treatment is surgical resection. Always, there can be surprises in medicine. This was a 1-year girl with cholestasis, severe itching, hepatomegaly, but on clear examination, you can see some amount of seborrheic lesions on the scalp. On retrospective history, asking the child had history of otorrhea also. And then we did the skin biopsy, and it turned out to be an LCH-related sclerosing cholangitis. So always we need to keep a possibility when they have a disproportionate scalp seborrhea and ear discharge with cholestasis. Intrahepatic causes, I already mentioned hepatocellular causes, and the secondary causes of interlobular bile duct porosity is actually the Alagille syndrome. Infections can cause cholestasis, bacterial sepsis, UTI, and herpes especially, it can cause liver failure. Various metabolic disease includes carbohydrate defects like galactosemia, lipid disorders, protein-related disorders like urea cycle disorders, tyrosinemias, glycosylation defects, mitochondrial disorders. And there are other few rare conditions that we see. And immune-mediated, the most important is HLH, neonatal hemochromatosis, and Coombs positive giant cell hepatitis. And from the familial genetic cholestasis, PFIC 1, 2, 3, and BRIC becomes possibility. So here is an 18-day infant who is exclusively breastfed, deep jaundice noted since 1 week of life, recurrent hypoglycemic attacks, coagulopathy, and inconsolable cry. On examination itself, we can see the child is sick, deeply icteric, and child has features of chronic liver disease. So this makes it as a neonatal acute on chronic liver failure. When to suspect MLA, I've already mentioned vomiting, failure to thrive, encephalopathy, seizures, hypoglycemia, abnormal body odor, strong family history of sibling death, and multiple systems involvement. So at this age, we keep this as the higher possibilities of galactosemia, tyrosinemia, gestational alignment disorders, even though it is slightly later for the GID, and also mitochondrial actually hepatopathy. On investigation, in milligram per deciliter, the bilirubin is 23 for this child. The child has already features of cirrhosis, and eye evaluation clinches the diagnosis here. We can see the oil drop cataract. Galt assay is actually done, and there is no enzyme activity in Galt assay, which actually speaks of classical galactosemia. The most important aspect of diagnosing galactosemia is you can beautifully see that the liver function starts reversing even within 48 to 72 hours of stopping the milk exposure. When you have a similar history with a history of recurrent abortions, IUGR baby, always we need to keep a possibility of gestational alignment disorder. They have severe coagulopathy disproportionate to the rest of the liver functions, and majority will manifest clinically within 1 week of life. This is another child with cholestasis who you can see that there is florid rickets there. And hence, cholestasis with florid rickets, the first possibility is always tyrosinemia, which is an amino acid disorder, which is due to the enzyme deficiency of FAH. Tyrosinemia is something like Wilson in the like the older children. They can have acute liver failure, CL, DHCCs, neurological crises, renal tubular acidosis, etc. So it can be a mimic of any of the diseases. Succinylacetone acetone, the urine, is usually diagnostic. NTBC is a drug which is one of the medical treatment, but ideally it needs to be started within 4 weeks of life. More than that, it doesn't decrease the incidence of HCC that drastically. And tyrosinemia is the metabolic liver disease with the highest risk of HCCs in the liver. So that is our experience of liver transplantation after decompensated livers in tyrosinemia and HCC. They have a very good outcome. Coming on to a child with itching. So a 9-month boy with intractable itching, many a times they don't have jaundice. Sometimes they have been treated like having seborrheic dermatitis, but somebody examines the child and they have a hepatomegaly. This is the usual story of children with progressive familial intrahepatic cholestasis. This is the second most important cause of chronic cholestasis in children, which becomes an indication even for a liver transplant in children. We need to remember that the GGT is usually normal in all type of PFICs except the third type of PFIC. And newer types are getting discovered. Among the type 1, 2, and 3, for the infantile liver disease, more applicable is type 1 and 2. The third type usually manifests a bit late. And gamma GT is actually low in type 1 and type 2 PFIC. Liver biopsy can give diagnostic clues. Genetics will clutch the diagnosis. I think that is our latest paper on the role of liver transplantation type 2. I think I've already explained that the genetics is actually expanding the monogenic disorders, the genetic cholestasis. So this is the TJP2, which is the type 4 PFIC, and we have reported the outcomes of liver transplantation in these patients. Coming on to another genetic cause of actually cholestasis. So this is basically a child, 10-month girl who had a history of cardiac surgery, now has history of itching, and liver biopsy was done, which was showing a paucity of interlobular bile duct. So this is the classical presentation of the Alagille syndrome. The clinical clues are basically they can have a triangular facies as age advances, then the forehead becomes more broad and triangular will slightly start getting less. They have actually high cholesterol in your blood slabs. The gamma GT will be high, pale stools, and it is in fact one of the differentials of biliary atresia. You have a diagnostic criteria for the Alagille syndrome, and if either of them, I think among the 5 criteria, 3 are positive along with the histological support or a single gene mutation, actually clinches the diagnosis of Alagille syndrome. This is one of the initial series which was reported from India, in which the incidence of biliary atresia, I think biliary atresia was one of the important causes of cholestasis, which was actually noted. Just brushing through the medical management. First of all, I mentioned that we need to identify a sick child. Because a sick child needs attention, we need to offer the treatment to the child, management of ABCs. IV antibiotics, I think we take them as having sepsis, and then we start on antibiotics as per the hospital policy. Stop milk immediately because it is a reversible cause. And HFI is one possibility that we see. So you stop if somewhat sugary products and all, if the child is already exposed. If there is a suspicion of hemochromatosis, IVIG plus exchange transfusion may help. NAC and vitamin E cocktail doesn't have much role in treatment of hemochromatosis, but it is always important to start IV acyclovir for HSV liver failure until 3 weeks or till the HSV PCR is negative. This needs to be given along with IV antibiotic in these children. Nutritional rehabilitation for a child with cholestasis is very important. They have higher BMR, enteropathy due to portal hypertension, recurrent infections, absorption is bad. Only MCTs are absorbed. So I think their requirement is slightly double than whatever the normal infant actually requires. So this is standard recommendation which is available over the web. I think the essence of this is 2 times RDA is the usual recommendation for these children. UDCA, I think we use it right and left. I think we exactly don't know whether it has got any benefit. Cholerasis, I think it increases the bile flow. It has got some antifibrotic, antioxidant effect. A few trials in PFIC, cystic fibrosis Alagille have shown that, especially in PFIC, the degree of fibrosis can be slightly lessened if you use UDCA, but the rest of the diseases, the benefit is actually unknown. Coming on to the last section of the talk, I think the non-cholestatic liver disease in infants. I think whenever a child with hepatomegaly comes, somebody who is having moderate to massive hepatomegaly, the important liver tumor that we need to keep is a hepatoblastoma, and the clue is given by alpha-fetoprotein, which is elevated even up to lakhs in majority of patients. There are a few rarer liver tumors which can happen in this age group, like rhabdoid, mesenchymal tumors, and even neuroblastomas. And the most important disease that presents with hepatomegaly without jaundice is again a glycogen storage disorder type 1A and 1B. 1B will be having neutropenia usually. Type 1A doesn't have. They are not cholestatic and they never land up in cirrhosis. They have HCC formation later. with, unlike the other GSTs, which can have a manifestation with cholestasis. Other disorders, systemic disorders like mucopolysaccharidosis, Gaucher's, and thalassemias can also have hepatomegaly, and we need to be cautious about these diseases actually presenting as hepatomegaly as a part of the systemic condition. So carry-on messages. I think we keep a low threshold to detect cholestatic jaundice. History taking is very, very, very important. Stool color is to be observed meticulously by the parent and the physician. We can't afford to miss a biliary atresia. All sick babies are not septic. Always we need to keep a possibility of an underlying metabolic liver disease. If a child has severe failure to thrive and there is an abnormal cause of sepsis, we are giving antibiotic, the child is not recovering, then we need to think of metabolic liver disease. And when they have an end-stage liver disease or a refractory metabolic crisis, the final option for treatment is only liver transplantation. Thank you, ladies and gentlemen, for the kind listening. Thank you.